The topic for the discussion today is From Deficit to the Discovery, Harnessing Hypoxial Inducible Factor for CKD-related Anemia. Our patient is a 65-year-old female. She is a known hypertensive case of chronic pyelonephritis with CKD since 2016. She reached end-stage renal disease in October 2019 and she was initiated on hemodialysis through right internal jugular non-tunneled catheter followed by left arm AV graft. She continued her thrice weekly dialysis, 4 hours each, using high flux single use dialyzer with adequate dialysis, and her interdialytic weight line is around 1.5 to 2 kgs. During initiation of hemodialysis in October 2019, her hemoglobin was 8.1 and ferritin was 245. Initially, she was initiated on erythropoietic 4,000 international units twice weekly subcutaneous along with oral ferrous fumarate. In Jan 2020, her hemoglobin is improved. It was 8.4, but it was not so good improvement. So her dose of erythropoietin was increased and she was continued on ferrous fumarate. In subsequent weeks, her the hemoglobin improved from 8.4 to 9.3 and 10.6 in July 2020. Her erythropoietin dose was decreased in July 2020. Subsequently, in September, her hemoglobin was 11.8. Hence, ferritin was also 620. Her both erythropoietin and the oral line was stopped. In October, it was 11.7, and in December, it was 11.9. In December 2020, she had one episode of left AV graft thrombosis. Hence, right arm AV graft was created, and she was continued on anticoagulation. In March 2021, hemoglobin dropped to 9.6. Hence, ERIPO was reinitiated twice weekly. Subsequently, in May, it was 8.2. TSAT at the time was 17 and the ferritin was 300. Hence, 2 doses of IV ferric carboxymaltose was given and she was continued on erythropoietin. In October, it was 11, and in May 2022, it was 11.3. So subsequently, the erythropoietin doses were reduced. In June 2022, after reduction of erythropoietin, her hemoglobin again dropped. Hence, the dose was increased. Subsequently, it reached 6.3 in August 2022. At that time, iron was 38 and TSAT was 23.1 and ferritin was 601. Hence, one dose of ferric carboxymaltose was given and the erythropoietin dose was increased. Subsequently, it was 9.2 and 10.2. Again, it dropped in March 2023. At the time, her TSAT was 21% and ferritin was 456. Hence, one more dose of IV iron was given and the erythropoietin dose was increased. It was subsequently increased in May 2023 to around 250 units per kg per week. In July, her hemoglobin further dropped. It was 7.6 with ferritin 346. Hence, the erythropoietin was stopped and she was given one dose of ferric carboxymaltose and she was initiated on oxemia desleuostat on non-dialysis days, that is 100 mg thrice weekly. Subsequently, her hemoglobin improved to 9.1 and 10.6. Hence, the same dose was continued. In October, it was 10.1. In November, it was 10.9. It was increasing. Hence, the dose of desleuostat was decreased to 50 mg thrice weekly. Subsequently, it was 11 and 9.9 after 4 months. Hence, the dose was again increased and it was continued for 2 to 4 months. Once the values reaches more than 10 or 11, the dose was decreased, and if it is decreasing, the dose was adjusted according to that. In September, her hemoglobin was 9.5. The iron status TSAT was 16.4. Hence, one dose of IV iron was given. Since then, her hemoglobin is constantly maintaining more than 10, and the ferritin is also more than 500 always. Hence, the dose of desleuostat 150 mg, that is actually the maximum dose, thrice weekly is continued, and she is maintaining the hemoglobin and the ferritin till now. This is the latest report in April 2025. That's all for the discussion regarding the case. I think my theoretical points are almost everything was discussed among the panelists previously. Only few things I wanted to highlight actually. Dream D and ND was already discussed. Actually, for the patients who are starting on the Distuas, this is the dose adjustment based on the hemoglobin value and the change in the hemoglobin percentage level every 4 weeks. Based on this chart only, we are adjusting the dose. I want almost all the people to see this chart and to adjust so that the maximum level is not reached within the smaller doses. And one more thing, we have to inform the patients that they should not consume any food 1 hour before and the 2 hours after taking the desogestat. These are the summary of the primary and secondary endpoints in peer-reviewed phase 3 trials in non-dialysis patients. In this, they have found that there is a significant increase in the hemoglobin compared to the placebo, and the HIF polyl hydroxylase inhibitors are non-inferior to the ESAs that as already discussed. It is seen that there is a significant reduction in the ferritin, hepcidin, TSAT and total cholesterol LDL, and there is a significant increase in the TABC. Whereas in the dialysis patients, there is a significant reduction in ferritin, hepcidin, DSAT, but there is no much change in the cholesterol values according to this peer reviews. Apart from that, it was almost similar for both the dialysis and the non-dialysis patients. This slide, I think already sir has discussed. These are the potential benefits. It is oral route so that it will be useful for the patients on non-dialysis. It increases or maintains hemoglobin levels effectively, and it increases the endogenous EPO production in physiological range. It is also regulating the hepcidin, and it is lowering and down regulating. It increases the iron absorption and is not influenced by the inflammation. It inhibits it reversibly, and it is also transiently. It is also lowering the cholesterol levels, especially in the non-dialysis patient. Almost coming to the end, I have a few questions to be answered in the future or in our discussion itself. Given that these agents are decreasing the TSAT and the ferritin levels, actually in pivotal trial, we are using both these biomarkers, TSAT and the ferritin levels. Then how to monitor the patients in desidustat based on these values, TSAT and the ferritin, which is a better biomarker for these patients on oxemia or desidustat. One question. Second thing, I think this is already discussed by sir. This is giving their ability to achieve the hemoglobin targets at physiological plasma erythropoietin levels. Could they be used to treat hyper-responsive patients more efficiently and safely? So still a query. Given their effects on iron mobilization, can they reduce the need for IV iron in patients with anemia of chronic disease in dialysis or non-dialysis patients? Still, we need more trials. Will their cholesterol lowering properties prove clinically relevant? We need more randomized trials to prove it, I think. Thank you.
Thank you very much, Khamini, for your excellent presentation, and for the presentation of these for a couple of years follow-up. And one question in the chat box was, what do you think is the cause of non-responsiveness to erythropoietin in spite of iron supplementation, etc.?
I think this patient is because of inflammation, sir. Actually, she's on dialysis for a few years. Other correctable causes like folate, vitamin B12, and everything was hyperparathyroidism. Yes. Everything was corrected. Maybe because of inflammation and the hepcidin increased hepcidin levels, she is not reaching her targets. I think we don't have facilities to measure hepcidin, so we are not using it actually.
Yeah. Surprisingly, the patient responded to desidustat. So probably there could be some more things which are unidentified. The Google is asking a question. Let me read that. Google's question is, could it be due to anti-EPO antibodies?
Possible.
Maybe, sir, but possible.
Possible. We have not done it. So that is the different reasons could be there. I am very happy that you have brought out the medicine to be taken 1 hour before and 2 hours after.
Yeah,
I never knew that. So that's a very important thing which you have conveyed to all of us, that the timing of the medicine should be also told to the patient. Any comments or questions about this, Dr. Vilesh or anybody? Khamini, thank you very much for presenting this good case. Any questions, comments
Sir,
about?
sir, regarding this timing of this medicine, I have
Yes.
had patients who are initiated on these drugs and they did not respond adequately initially. So when I asked about them, they told like they were not following the timing. So now what I am following is like I tell them to take immediately 1 hour after breakfast on Monday, Wednesday, and Friday, and not to take food for the next 2 hours if possible. So for those patients who are initially non-responsive, after changing on to this regimen, their hemoglobin started to improve actually. That's one practical point here.
Thank you.
Just
Any
one
other
point, Dr.
Yes,
Khamini,
Sadish.
your patient, you saw that multiple times the iron status, the iron
Going down.
PSAT was 16%, 15%, all that. And you are giving 500 milligram ferric carboxymaltose. That's quite a high dose. Almost every month it was being given, once in every month or once in 2 months. So was there any bleeding, GA bleed during that
No,
time?
sir.
Or something like that? Was
No,
he
sir. No,
evaluated for that? Nothing.
no. Otherwise, she's a stable patient actually. No other incidents in between. She's on regular dialysis and she's continuing thrice weekly and with good
Whether you have
compliance.
done a stool local blood or something. Some of these bleedings can be very, very tricky.
Very
To
microscopic.
pick up. Yeah.
Thank you
Very
very
good.
much. Any other questions, comments? So if not, then thank you, Dr. Khamini, for an excellent presentation.